and today's session is reproductive concerns. My name is Catherine Grennan, and I am a heart transplant mom. And I'd like to introduce my daughter, Hannah Grennan, and she is an infant heart transplant recipient. And in our session today, we have Lisa Coscia, and she's the senior research coordinator at the Transplant Pregnancy Registry International, TPRI. We also have Dr. Frederick Licciardi, professor of Obstetrics and Gynecology at New York University, Langone Health. You might have to correct me on that, doctor. And then also we have Dr. Ashley Roman, Obstetrician-Gynecologist at New York University, Langone Health. And finally, we have Kim Uccellini, Policy Analyst and Pediatric Transplant Recipient at the United Network for Organ Sharing. So we'd like to welcome you to today's conference, and we're going to start off with Lisa, if you would.
Thank you so much for allowing me to be here today with this panel. I'm just going to start out with a short video that we produced that I think everybody will find really heartwarming.
I always thought about having kids, starting my own family. I was always told that I couldn't get pregnant. I was so excited just to have kids.
That first touch between the baby and the mother is beautiful. I didn't think I could become a mother.
I'm so glad that I spoke with the Transplant Pregnancy Registry International before I was pregnant and was able to be helped by them, because now I have my two lovely children. Just to watch them grow and become little people, I could have never imagined when I was thinking about getting pregnant. The registry can provide fact-based information that can really clarify all of your questions.
The mission of the Transplant Pregnancy Registry International is to make sure that every transplant patient who wants to have a pregnancy gets the best information available for them.
There are risks. The success rate is not 100%, but the success rate of pregnancy isn't 100% in perfectly healthy people. Nothing matters more than planning pregnancies so that you maintain your good health, which is essential for the health of the child. There was great skepticism that pregnancy was safe, that it was threatening to the transplant organ. The medications were threatening to the fetus. We now know in a very quantitative way that that's not true.
I had been told that I couldn't breastfeed, and the breastfeeding report told me I could, and it was such a relief. We could make informed decisions as a family.
I feel that organization like TPRI, they are doing a fabulous job in helping us. Having knowledge in advance is very powerful.
Because someone said yes to organ donation, I am alive to raise a family, experience things that I wasn't able to as a child. Nayala, the oldest, she's about to be 3. Naraya, my middle child, she's about to be 2. My youngest, Zion, he's 4 months.
The first gift, of course, came from my father when he gifted me his kidney. The second gift has been my son. His name is Veer Puri. He's 3+. I'm very blessed.
My son Max is 5 and my daughter Jean is 3. They're very energetic children, keep me on my toes.
What's very powerful is the circle of life. It all begins in organ transplantation with the gift from the donor that then gives the transplant patient renewed health and the potential to create their own family through pregnancy.
Don't second guess about signing up TPRI will always be there for you.
I'm just so grateful to be here today.
I have been given far too many gifts in my life, which have made my life beautiful and joyful.
I'm looking forward to watching my kids grow into who they will become in life.
Wow. Thank you, Lisa. That was just so inspiring, and I know for us as well, and for Hannah. And we do have, looks like we have some chat questions. I don't know how you'd like to proceed, if you'd like to say a few words first, or if you want to go into some chat.
I think maybe we should let the other presenters speak, and then I think we could go into answering the questions, just so everyone
You bet.
gets
Great
some.
idea.
Yep.
Great idea. Okay, so next we have Dr. Frederick Licciardi. I'm sorry, Doctor. And so would you proceed with your presentation?
Sure. I'm Dr. Frederick Licciardi. I'm at NYU, and I thank everyone for inviting me and for being on this conference. So, you know, fertility, when people hear infertility, is such an emotional word, whether you're a transplant or not. It really just really racks your whole body. So let's start with, it's almost all good news. Okay. Most people get pregnant very easily. The human body is just resilient to stress, to adverse events. So I think really the message is fertility is something that we should not be afraid of when we talk about people in your condition. Now, the drugs that a woman or a man takes for their immunosuppression do not affect fertility. So that's great news right off the bat. Things where we can run into trouble is very specifically when you're talking about renal transplant and those people who may have needed chemotherapy prior to their transplant to reduce the renal inflammation. So Cytoxan specifically can be difficult for fertility, and the way it does is it hurts your germ cells. So what's that all about? So men or teenagers and men, they produce sperm. These sperm come from cells in the testicles that are always reproducing new sperm. And these are sensitive to chemotherapeutic drugs. It's a little different in adolescents and women. Women, as many of you know, actually you're born with your eggs and you never produce any more. I hate saying this, it sounds so mean, but it's really true. There's never more eggs produced. So any eggs that you have there, you have to protect. And so the Cytoxan, depending on the dose that's given, can affect egg production. And so that's a discussion to have with the doctor. What is the dose? Because there are different protocols, and they're actually all alternatives. Now, sometimes the alternatives aren't really the best drug for the outcome in each specific case, but there are alternative Cytoxan. So the way we analyze fertility, fertility on the men's side is different than the women. Men's side, it's very easy. What's the sperm count? If you bake a cake, the sperm is like the yeast. If the cake doesn't rise, you know what the problem is. On the women's side, there's so many factors that go into the cake that we never know for sure. But one thing we do want to focus is on reserve. So this can be measured by a hormone called AMH, anti-Mullerian hormone. This tells us about the range of the eggs that are present, the numbers, and going forward. But that's just one very specific. It's an important issue. It's one very specific. Otherwise, if you or your children are not taking these cytotoxic drugs, we're just expecting very positive things on the fertility side. Certainly, there are problems related to infertility, unrelated to transplant, et cetera. But our goal is to just give it a go to see what happens. And usually people are very successful. Dr. Roman's going to talk about the pregnancy issues that occur afterwards. But I think the fertility side should be very optimistic.
Okay, great. Thank you, Dr. Frederick. That was a wonderful explanation. And so next we'll have Dr. Ashley Roman. So Ms. Roman, Doctor.
Thank you so much. So a couple of things about me first. One is I specialize in high-risk pregnancies. So I'm the kind of doctor called maternal fetal medicine. And it's a form of an obstetrician. We've got extra training after OBGYN training so that we can focus on high-risk pregnancies. In many ways, our job is to kind of coordinate all the different specialists that need to be involved in the care of people caring for high-risk pregnancies. On the other side, and I think it's important to mention on the personal side, I am a transplant recipient myself. So I was born with polycystic kidney disease. I learned in my 20s that I had it. At that time, I knew I probably need a transplant at some point, and I received a kidney from my brother about 3 years ago. And so I really intimately know the effect that needing an organ from somebody else has on you personally and has on your entire family, whether it's your extended family currently or your future family, which is what we're talking about here. And I just feel so privileged to be able to speak to you all today about my experience being a doctor and caring for high-risk pregnancies in people who are transplant recipients. So as I approach this from a maternal fetal medicine perspective, the most important thing I can say is for anyone who's a transplant recipient who's considering pregnancy, the most important thing is to see somebody like myself, a maternal fetal medicine specialist, before you even conceive. Because that's the time for us to sit down together to figure out your background, your history, your medications, and talk about the risks are associated with pregnancy and come up with a plan. So during a preconception consultation visit, some things we would be going over are, when was your transplant? What is your graft function? And who's caring for you? What medications are you taking? And are they compatible with pregnancy? Is there a genetic component to your disease? So certain cardiac indications for transplant and certain, other diseases that can affect lungs, indications for lung transplant, indications for liver transplant, indications for renal transplant, they can be inherited or are associated with increased risk in your offspring. So we would be sussing out for any genetic component to the reason why you needed a transplant in the first place. And then the other consideration is number of transplant recipients also have other issues that are kind of tangentially related to the indication for transplant, such as hypertension. High blood pressure is really common in people who've received a transplant. Other things we can see in transplant recipients are diabetes. So some of the medications we take to suppress our immune system can be associated with a higher risk of you developing diabetes. So we're going to want to know if you have diabetes going into a pregnancy. Once we gather all of that information, the next step is to have a discussion about what are risks associated with pregnancy. And in general, regardless of the organ somebody has received, there are a number of risks that organ recipients are at higher risk for during pregnancy, including preeclampsia, which is a form of high blood pressure that can be caused by the pregnancy. And there are things we can do to reduce the chances of that happening. So we're going to want to have a conversation about that. Other risks that can be associated with pregnancy are rejection. So one thing that pregnancy is associated with is it can affect your drug levels. And so there may be a higher risk of rejection during pregnancy. We do know that pregnancy is also associated with higher risks of infection, particularly urinary tract infections. So we're going to be wanting to, we'll discuss that, how to prevent that, signs and symptoms of urinary tract infections, and gestational diabetes. So gestational diabetes is a form of diabetes that's caused by pregnancy. People who come into pregnancy on certain immunosuppressants may have a higher risk of developing gestational diabetes. So we would be having a conversation about that at the time of the preconception consultation. One of the most important things that we'll be talking about at preconception consultations is what medications you're taking. And believe it or not, most medications that people take for immunosuppression are safe in pregnancy, including cyclosporine, tacrolimus, azathioprine, prednisone, and most blood pressure medications are safe and compatible with pregnancy. But there are medications that are not. So medications that we are going to want you to transition off of into another safer medication before you conceive are medications like Cellcept or mycophenolate, because that can be associated with an increased risk of birth defects. Other medications we would not want you to be on during pregnancy are class of drugs called ACE inhibitors, which can be used for blood pressure control, or angiotensin receptor blockers, also as a medication for blood pressure control. So we would want you to be off of those three types of medications before you conceive, because they can be associated with an increased risk of birth defects. And then when assessing the risk, the absolute risk of any of these complications in pregnancy, we're going to be looking at what your kidney function is, what's your renal function, what's your cardiac function before you conceive, because there may be some instances where we might recommend that you delay getting pregnant. So for instance, a kidney transplant recipient whose creatinine is rising, whose serum creatinine is rising, and they're starting to go or heading towards end-stage renal disease and the need for another transplant, we might advise that you wait to conceive until after the next transplant. And for instance, if we're talking to somebody who's received a heart transplant, for instance, we're going to want to know what your cardiac function is and whether there's signs of vasculopathy before advising that it's safe for you to conceive. So there might be circumstances in which we might say, hey, let's wait for another transplant before you do get pregnant. In those cases, that might transition into a conversation about contraception. So as Dr. Licciardi touched on, patients who've received an organ transplant, they can conceive and they can get pregnant. So it is important to use birth control if pregnancy is not on your immediate horizon. And there are a lot of different forms of contraception that are safe to take when you've had an organ transplant. IUDs, for instance, whether it's a copper IUD or progesterone IUD, those are safe. There was previously some concern about whether putting a foreign body like an IUD into the uterus could be associated with a higher risk of infection. There are also concerns about whether they would actually work well in somebody with a compromised immune system, but they do work well and they do seem to be safe in somebody who's on immunosuppressants and who's received an organ transplant before. Other forms of contraception are progesterone implants. That's something that could be considered, and or birth control pills in birth control pills in some patients that contain estrogen may be considered as well, just depending upon somebody's past medical history. So bottom line is, it's complicated. It takes a village to manage patients who've received an organ transplant safely through pregnancy. It will require a lot more intensive surveillance during pregnancy to make sure the fetus is developing normally, to make sure that your blood levels of your immunosuppressants are appropriate, and to look for any signs of pregnancy complications. But again, it can be done really, really safely. And I also want to shout out Lisa again, because as a physician, we use Transplant Pregnancy Registry International. It's extremely reputable. They're very accessible both to patients and to physicians. When I give lectures on this to the Society for Maternal Fetal Medicine, I do call out Transplant Pregnancy Registry International as an important resource for physicians just as much as it is for patients. So I would advise, please feel free to use them as a resource, just as much as you would use your maternal fetal medicine specialist or your fertility specialist like Dr. Licciardi. So again, thank you for this privilege of speaking to you today.
Thank you so much, Dr. Roman. That was just absolutely fantastic, really fantastic. And so next we have Kim Uccellini, finally, and really looking forward to hearing what you have to say. So thank you very much.
Can everyone see my slides? Are my slides showing, Catherine? Great, thank you so much. So I have the pleasure of trying to connect all of these dots and wrapping up this presentation before any questions. As Catherine introduced, I am a pediatric kidney recipient, obviously many, many years out from that. And I'm a mom, so I am here to share my personal experience. And as I am a visual learner, I did prepare a few slides just to kind of help guide the story along. So I'm going to really focus on sort of the process that I went through in trying to determine whether I should even pursue children and starting a family. Far less content on sort of my pregnancy journey and birth story. But I'm also happy to take questions on all of that if anyone has any.
Okay.
So these are my two kiddos. Isla is 6, about to turn 7, and Shay is 4. And sorry to getting a little emotional. I always do. They are the loves of my life. And I think like most recipients, the hope is, after you're transplanted is to live as normal a life as anyone else. And so while, I wasn't contemplating starting a family at 9 years old when I was transplanted, it's certainly something that I am super happy that I thought about and consulted a lot of folks about and ultimately did. So just to kind of give you a little bit of background on my story. So I was born with renal dysplasia. So my right kidney never fully formed. And by the time my pediatrician discovered something was going on, I was 4 and my left kidney function was declining. So when I was 6, I was put on dialysis. I did hemo and peritoneal, and I waited 2.5 years for a transplant, was called 3 times. Third was the charm. So in 1989, over the summer, luckily, I received my transplant at Children's National Medical Center in Washington, D.C. And I don't really, fortunately, have much to report since that point in time. So I am almost 33 years out, which is pretty fantastic. And I will touch on a couple of things that might make my situation maybe atypical, but I hope not. But yeah, it's been many, many years. I've had 3 times as many healthy years as 6. So I am super fortunate. So when I started to think about having children, I was probably in my early 20s. Just to put it out there, when I started to have, thinking about this, just to know about me, I didn't have any additional pre-transplant comorbidities. So I didn't have any other additional problems other than, the kidney issues that I had previously described. Since being transplanted, I also haven't had any complications or issues, literally none. And as Dr. Roman touched on, never been diabetic, don't have hypertension, and, just didn't really have anything and continue don't have anything else going on. So, just because parents might be interested, kids, sorry if I'm grossing you out, but I had a very normal puberty. And since that point in time, it was pretty normal everything, if you catch my meaning.
Right.
So since I had such normal puberty and everything else was, sort of in working condition, if you will, in my early 20s, as I mentioned, I started asking myself, did I even want kids? So certainly there's a risk. And I thought that even before I started doing a lot of digging and research, I knew that there would be a risk, right? I wanted to know that my family would be comfortable and that they were on board. And at that point in time, in my early 20s, I didn't have a partner, or at least one that I was going to commit to long term. But I wanted to ensure that eventually, whomever I ended up with, that they would be comfortable with the risk that obviously would be involved. And then, of course, how would my medical team feel? Obviously, very important. So asking all of these questions, and I just want to say, so I asked not a single medical team, but actually 5 different teams as I've been so many years post-transplant. After college, I moved around the country a little bit. So I didn't put with these bullets exactly what centers that my teams were a part of, but I'll just mention what part of the country that they're from. So in my early 20s, when I had no partner, and I asked my adult nephrologist at that time if kids were in the cards, if it's something that I should avoid completely. That particular physician said, "I don't see why not. You're otherwise very healthy. Go forth." So that was in Northern Virginia. And then in my mid-20s, I relocated to the Northeast in Connecticut. And the first nephrologist, again, adult nephrologist I was seeing in that neck of the woods was not comfortable, less comfortable, I should say, and advised that she wouldn't recommend it. So then I ended up seeing a different, transferring to a different center in the same part of the country. And those nephrologists were very forward thinking and said, this was my late 20s at the time. Again, I'd met my future husband, but we were not yet married. And she said, go have kids, do it now. You're in your late 20s. You're in the prime of your life. And I was like, okay. Then we relocated back down to Virginia, where I am now. And I was living in Northern Virginia at the time. So obviously my care had been transferred. I was seeing a team in Washington, D.C. That particular nephrologist said maybe, but there's definitely a risk, and we can't really quantify what that risk is. Speaking specifically about rejection and sort of shortening the lifespan of the kidney is really what she was referring to. And so then we relocated to Central Virginia. And so the center that I'm still followed at now was just hands down, no, we don't care that you're 30, at the time, 20, late 29, 30 years out, no issues. We just don't recommend it. And so my sense is that, these various teams probably had varying levels of experience with, recipients in pregnancy. I think what experience they had were probably, at least to some degree, folks who had accidentally got pregnant and not necessarily had planned pregnancies. At least that was the case for my current center. And, the folks who seemed to be on board with it tended to be younger and actually did know about the Transplant Pregnancy International Registry. So they were the ones who asked, told me to go find this source, lots of great data. So I also want to give a shout out to Lisa's team there. And so that's kind of what I did. So I took this collective sort of sentiment that was a little bit all over the place between yeses and nos. And then I started digging into the Transplant Pregnancy Registry International's data and saw that, honestly, for someone who looks very similar to sort of my case, pregnancy seems to be, an okay thing. I knew my drugs or the regimen that I'm on right now, which is still cyclosporin and azathioprine, 33, years later, that those were now considered safe. I think at some point in time, azathioprine was questionable, but is now considered one of the safer drugs. And then I also found a group on Facebook, the Pregnancy and Motherhood and Organ Transplant Facebook group. It's only open to females, but that was also a really great source of information. And so all of this together and talking to my now husband and my family, my current husband is obviously, he's amazing, and he really wanted a family. And I said, let's give it a shot. And my regular gynecologist referred me to my current center's maternal fetal medicine team, saw an amazing physician there, and guided me through 2 safe pregnancies. I will say that I did experience preeclampsia both times, but otherwise they were both very normal, boring pregnancies, not atypical from, I think, anyone else's. So takeaways: talk to your family and your partner if you have one, or when you get one, of course, talk to your medical team, analyze the great data that's out there. And then, of course, as Dr. Licciardi and Dr. Roman touched on, involve those folks as well and ensure that, you have a team to support you. So thank you so much for giving me this opportunity to share my story. Happy to answer any questions about what went into planning for a family or my pregnancy or birth. So thank you.
Well, those were all really great presentations, and we're just looking over. We've got some time to take some chat questions, so I'm just going to pick a few if you don't mind, just randomly. Basically, we have actually some very young people just chiming in, so that's really exciting to see. 13 and 14-year-olds basically saying 14-year-old boy awaiting heart transplant. So already at this age, they're thinking about, I mean, this young man hasn't even had a heart transplant yet, and he's already thinking about a family someday. So does anyone have any encouraging words for him as far as from the boy's perspective? Maybe Dr. Frederick, maybe, I don't know who actually mentioned boys. Okay.
No, it's okay. I'm
Yeah.
the oldest of seven. I'm the oldest of 7 kids.
Very good.
We're 6 boys and a girl. So even though I talk to mostly women all day, I'm comfortable enough with boys. So
Great.
Anyway, thanks for that. Listen, thanks for the bravery to come to this conference, to put yourself out there, to tell people what you're going through. It's such a big deal. I appreciate it. And I don't want you to worry. There's some talk. There's really very little talk about fertility in boys. You're not going to take any drugs that are going to interfere with your sperm count. And so that's the whole thing. Outside of just what general people get, like your transplantation should not interfere. Now, there could be a little bit of stress-related reduction in your sperm count, but this is all manageable, either just giving it more time or using certain medications, which probably will not be needed. So just from my perspective, I think you're going to be just fine, and I'm looking forward to seeing your kids someday.
I think just in general, we haven't seen any problems with men fathering children. And like Dr. Licciardi said, no problems with the medications. There is one medication, sirolimus, that there's been some studies that show it might decrease the sperm count, but when that's discontinued, the sperm count can rebound and not have any problems. And overall, we don't see any problems with the outcomes in men fathering children. They look very similar to the general population. Women sometimes have a little bit smaller babies and they're born prematurely, but we don't see that with men. So good luck with getting your transplant to that young man.
That's great. I actually, maybe Hannah and I wanted to get in a quick question real quick, if you guys don't mind. Hannah is one of 7. So Dr. Frederick, we kind of know but she's the youngest. Mm-hmm. So she has 5 sisters. And of course the plan, when we were told no over the years that it just wasn't possible, the plan B for the Grennan family was always surrogacy, to actually have one of her sisters carry a child for her. So do we have any information or a path to that situation? Has anyone encountered that with the registry or anything?
Yeah, definitely. Because there are some situations where patients should probably not have a pregnancy. So surrogacy is an option also, where you can go through the process and have someone else carry the child. It's variable, depending on the situation. I think the biggest barrier for surrogacy sometimes is the cost. Right. As with in vitro fertilization, because not many insurance companies will cover the cost of that. I think that can be the biggest barrier sometimes.
Yeah, but more insurance companies are covering in vitro. These, like 70% of our practice, which is huge, get some sort of coverage, which is really nice. And if you use a sister, that's maybe she'll give you a discount. I don't know.
I think we got that covered. Go ahead, Hannah.
But carrier is also carrier is not there should be no mystique about carriers. Carriers are so common. It's so commonly used. It used to be quote unquote a little weird, but it's just the way of the world now. So that's awesome that you have the opportunity.
Yeah, I have a quick question. The thing is I take a low amount of anti-rejection meds, and I'm pretty fortunate to do that. Does the amount of medication affect fertility or being able to have a healthy pregnancy at all? Is that like a positive thing, or what have you gathered in that sense?
I think we're just neutral. I don't think it matters. If you need to take a little bit more drug, you take a little more drug. I don't think that's going to be an issue.
Okay.
And I don't know if we have time today, but I'm very happy to explain how carrier works and IVF and all that stuff. So whatever we need to fill up the time.
Okay, thank you very much.
Okay.
I think what we also see, just to let you know, Hannah, is sometimes during pregnancy, you might need more medication than you do now, because there's an increase in distribution of the medication. The fetus does metabolize some of the medication also. And what we see is a need to increase that dose during your pregnancy.
Right.
And based on the trough levels, because the trough levels do go lower during pregnancy.
Okay. Well, I'm trying to look through some more of the comments here, and like I said, we've got really young people chiming in, and honestly, I've got to say, it's kind of the same question, just multiplied over. So I think that we're really at a point where we've got teenage children, 11-year-olds to 16-year-old, just really already thinking about this. And I think as we, for our family and for being involved in transplant families, and especially this session, we're very excited about the registry, number one. So I'm going to comment now. We're very excited about the registry. I personally have a girlfriend that I met through the organ donation world who is a liver recipient, and she worked with her team in Georgia and was able to have a wonderful, healthy baby boy. But she did work on a nice plan with her doctors. And so fortunately for Hannah, we've been trying to tell her over the years that it's just getting better year after year. And I would say to any one of these young folks that are commenting that in medical terms, it's a year is light years. We can learn so much in a year or 5 years. By the time they're ready to have a family, that there's so much good going on. So I'm really encouraged to see all of these comments. But like I said, it's kind of the same comment over and over again. So is there anything else anyone would like to? Yes, Dr.
Catherine, if I could just comment, I think Kim really touched on a theme that I see in a lot of my patients, which is how do you pick a doctor? And especially when you're getting conflicting advice, who's right? How do you navigate that? And what I would say, I know from the patient side, it can be really hard when you're hearing different information from different people, even if it's a doctor who's been caring for you for years and years and years. What I would say is, in my experience, I think it's important to get a sense of the experience of the doctor you're seeking advice from. And so, for instance, when speaking with a nephrologist or cardiologist, whoever is managing you at a baseline, you're going to want to get a sense of how many of their patients have gotten pregnant and what their experience has been. Same thing on the flip side. If you are seeing a maternal fetal medicine specialist or even a general OBGYN, a key question is, what is their experience managing transplant recipients, and do they work at a transplant center. So I do think if you are able to seek obstetrical care at a transplant center, I think that's really helpful, because then you know wherever you're going to give birth, you have access to all the specialties and subspecialties you need during the course of that pregnancy to remain healthy. So, for instance, when I work with couples or transplant recipients in pregnancy, I'm constantly communicating with our transplant center and the other specialists involved in their care. And as I touched on earlier, it often involves weekly visits, weekly lab tests, weekly visits either to me or to the other specialist, and then careful planning around the time of delivery, which in most cases is probably the most normal part of the pregnancy.
Yeah.
Normal vaginal birth. You can get the epidural. You can be comfortable throughout it all. But I know it can be a challenging experience. Choosing your doctor. And bottom line is, you want to choose a doctor who has experience in this.
I think that's just to kind of touch base on experience and speaking with doctors that I've known doctors for 24 years that have seen me in adult cardiology, and I think that, a lot of them have said we're not experienced enough in this type of information. So they're giving me all that they know. And I know that they know a lot, but I feel like there's so many questions that I have that they don't have the answers to, that I personally just want the answers to. And so that's kind of why I was really excited to do something like this, because then I could have all the information. If I need to go to a different state in order to find that specialist that's going to help me through that process, then that's what I want to do. And that's kind of, so when you say that I need to pick the right doctor that knows every single possible outcome that could happen, and that could help me through that, it's just like, it's so eye-opening. And it's something that I've had in the back of my mind that, there is someone out there that could help me and that could, ultimately do what I typically would love,
Yeah.
So
that's exactly what we did with Hannah's transplant. When she was diagnosed in utero at 18 weeks, we had, in 1985, had already lost a little boy to hypoplastic left heart, and we didn't have a heart transplant option at that time. And so when Hannah was diagnosed, we were kind of in this kind of parallel situation now, where we were searching for a center that had great outcomes for waiting, great outcomes for delivery, and great outcomes for transplantation. So we kind of feel like now we're in that situation again, where now that we're coming to a birth plan, we're going to search for, like you said, Dr. Roman, we're gonna reach out and we're gonna search for the best that we can find, for her. And just like we did when I was carrying her. So this is a really exciting time, very exciting time, to be a heart recipient or an organ recipient. So we really appreciate all that you've done, actually.
And on the flip side, I know as a transplant recipient how much you need to advocate for yourself.
Yes.
I mean, it can be, I'm a doctor, and even for me, it's overwhelming about, trying to figure out where can you get the most accurate information.
Right.
So I totally get it. And it takes a lot of work, and it really, it involves the whole family.
It really does.
It's not something you go through by yourself. It involves, it totally changes the family dynamic. And so kudos to you for recognizing that and doing that.
Thank
I
you.
do see some questions in the
Yes.
chat.
Yes.
I think one is going back to mycophenolate or CellCept. And earlier I mentioned that it is important to get off that when you're a woman considering getting pregnant. It's something that you should go off of before you conceive. I think one question is around the timing. When should you go off that? usually we recommend people go off it in our practice about 3 months before they conceive, or at least 3 months before they conceive. And that's for two reasons. One is we want it to be out of your system. And so that there's no chance that any residual drug could affect the developing embryo. The other reason is to wait at least 3 months is when you go off of it, your doctor is likely going to substitute a different drug in its place. And we want to make sure that going off of Cellcept or mycophenolate and substituting in the new drug is not associated with rejection. So we want to make sure that you're stable on your new drug regimen before you conceive. I see another question about genetic testing. There's a comment that someone did genetic testing to see why his child had kidney failure to help his kid with his family planning. So, and asking to comment on genetic testing. So, for instance, when you meet with your specialist, your cardiologist, your nephrologist, or when you meet with a maternal fetal medicine specialist, we will be asking whether there's thought that there is a genetic component to the disease that led to the organ transplant. And at that point, if the answer is yes or possibly, we may refer you to a geneticist to do some genetic testing to see if you carry a gene or we can identify a gene that could be inherited by the fetus. The advantage of that is if we are able to detect a gene that is associated with your disorder that led to your organ transplant, there's a possibility of sending you to a fertility specialist like Dr. Licciardi, who can do IVF with pre-implantation genetic diagnosis to select an embryo that does not have that gene. Or if that's something that you don't choose to do, we can test the fetus during pregnancy with an invasive test, something called an amniocentesis, or a chorionic villus sampling, where we take out some fluid from around the baby, or take a biopsy of the placenta, and we can tell if the fetus has inherited that gene. So it does, if we know that you have a gene associated with whatever disorder, we can potentially either test the fetus or select an embryo that does not have that genetic disorder.
I also noticed that there's a question about sirolimus in pregnancy. And we're starting to gather a little bit more information, but it's not 100%. We just don't have enough outcomes like we do with cyclosporin and azathioprine and tacrolimus. We think it might be okay, but it's still one of those drugs where we can't say with 100% definitive saying that yes, it's okay to take during pregnancy. So it's a little bit difficult. It's one of something that we need to look at as a risk-benefit ratio. Is the mother going to be better on that medication during pregnancy versus not being? Because really the bottom line is we want the mother's organ function to be 100% before pregnancy, because that's really going to help guide how a patient does during pregnancy. So it's a little bit of a gray area with that medication.
I see another question is, what is the appropriate way to ask for a second opinion when a doc says no to pregnancy? And I'll give you my perspective on it. I'll be curious to hear what Dr. Licciardi's perspective on it is as well. One is, it goes back to my earlier comment to Catherine, which is sometimes it really does take a family to advocate for it. And you can always seek out a second opinion on your own. You don't need to necessarily ask your primary doctor for that. But I would say that any good doctor is really open to that possibility, especially if they understand, like they have a good sense of their weaknesses. And especially in the maternal fetal medicine world, I do find that even in my own patients, offering to send them someplace else for a second opinion gives them a great deal of comfort. So I encourage that for my patients. It helps them to gain confidence in their care. And I don't think anyone should be afraid to ask for it. Dr. Licciardi?
Yeah, no, I agree. But the key is, it's okay to gather information. So if someone tells you no, your response should be, okay, that's fine. Let's just go through the reasons why. Like, why are you specifically saying? And then there might be a short list, it might be just 1 or 2 or 3 things, but at least then you can bring that to another doctor and say, listen, I heard that there's a certain percentage of this, or there's a certain risk of that. And then you can work that out with your next, or even, you can get more than 2 opinions also. That's okay.
Right.
And I'd like to piggyback on that, because that was kind of my experience, is that my doctors, at least some of them, the ones who were the maybes to the nose, really couldn't give me concrete reasons why I couldn't pursue it. Someone in my unique circumstance with my health profile. So I had the experience both of seeking, second, third, fourth, and fifth opinions, just because of, geographically relocating. But within my current center, it was the medical director of the transplant program who was adamant that she was, against me trying to get pregnant. But she did refer me to one of the younger nephrologists in the practice who I spoke to, who's fabulous, and said, you know what, generally speaking, we don't recommend this, but based on your unique case, we don't think that you would experience any issues that we can, kind of see. So.
Right. And she may have had, you don't know, sometimes there's a specific experience that's bad. Like that doctor, I'm just speaking for her, she may have had a really bad outcome one time out of hundreds of cases. And she was very concerned about you. And she thought about that, but maybe didn't want to tell you. So you really need statistics. You really need to, whatever statistics you can garner, whatever you can get, you need some numbers.
Did you want to say?
Oh, I just know from personal experience that I've had, multiple doctors at Loma Linda have told me, we're not going to tell you what to do. I had one doctor tell me that she goes, I'm not going to tell you what to do because you're an adult, but I will give you the side effects. I will give you the outcomes of what we have seen personally in their facility. And I've also had another doctor tell me flat out, no, you will never ever be able to have a child. And it's, so I've had a lot of opinions, but I haven't had a full concrete reasons as to why you're saying that particular answer. So, and that's kind of where I'm coming from as well, as if you're telling me no, I want to know exactly why, not because you don't know, but or I want to, if they say you could try, I want them to tell me, give me a plan. There's they know more than I do, so that's kind of the answers that I've personally experienced. Is it's a lot of question marks, and I understand why that is. I know that it's a very touchy subject, and I know that there's not.
I will say, Hannah, right after Hannah's heart transplant, of course, she didn't know this, but she was transplanted by Dr. Leonard Bailey. And, you couldn't have asked for a better guy, the pioneer to do her transplant. And one of the first things he said to me in recovery was, you have now become your child's advocate, and we don't know everything. Mm-hmm. And he said, you may have to tell us what to do. And honestly, that empowered me so much as a scared mother who's just looking at this baby, just transplanted. And I thought it was really great on his part to really admit to me that, I'm going to have to, fight for her sometimes, and it's going to be okay. So all of those,
we doctors don't know everything. I think that's the bottom line. Yeah. And it's true. I mean, and that's the role of shared decision making. Like, we can give you the data, but we don't walk in your shoes. We don't know, what your life was like. There's so many considerations to take into account. So I think presenting the data and helping you decide, that's our role as physicians, helping you to make your own decision.
Yeah. I don't know how much time we have left, maybe a minute, and I have something blocking some of my comments. So if any one of you see one last comment that we could cover real quickly, maybe we could do that, because I'm I got a pop-up that I can't get rid of. I'm sorry.
Well, I just want to make one comment that none of these medications are going to act as birth control in boys. They need to practice safe sex practices as well and use birth control. So just to clarify that these medications will not, prevent them from becoming parents. So they need to use, safe sex practices as well. And I think Zoe just wanted to say that Jennifer Rodriguez was the winner of the door prize for this session. I guess, okay. Catherine.
Okay, yeah, sorry. I'm so sorry. I've got some sort of blocking my text. I apologize.
That's okay.
But so did Zoe say we're coming up on a close? I have 9:55 right now. Okay. Yep. Well, from Hannah and myself and transplant families, we just honestly thank all of you for taking the time today, and also not just today, but preparing for this conference. And of course, certainly all of our sponsors that brought this conference to us. And we really thank you so much. And it's personally meant so much to us personally. And it is, Kim, you were getting a little emotional earlier, and I really do feel that. I feel like we can come away, and I hope all of our little young folks that were commenting can feel like that they can maybe rewatch this and or have their parents go to the registry and really start working on a plan, because it's never too young. Almost like your college plan, you just got to work this out. But thank you all so very much. This has really been enlightening. Thank you.
Thank you.
Thank you.
Thank you.